But the second session is actually on dysplasia surveillance in IBD patients who are in remission. And for this session, we've got a very nice talk by Anna Wilson coming up. So she's a colleague from the UK, consultant gastroenterologist at the St. Mark's Hospital in London. She's got a special interest in interventional endoscopy, particularly when it comes to dysplasia detection. She's been part of the newly developed and newly published BHD 2025 endoscopic surveillance guideline for IBD patients as well. So please, Anna, you can take the floor.
Thank you very much. So I'm just going to take us back to the beginning about why we offer colonoscopic surveillance for patients with inflammatory bowel disease. And clearly, the forefront of our mind is that we want to prevent IBD-related colorectal cancer. And that's because we know that patients with IBD are at a higher risk than the general population for developing and dying from colorectal cancer. What about the risk of cancer death in IBD? So looking at more recent population-based studies, you clearly see that the risk of cancer death risk in IBD is lower than it was over the last 20 years. And that's probably multifactorial. So there's significant impact of reduction in smoking. Better disease control is a huge driver. There's more effective surveillance, and we probably are doing more timely colectomy. So when we looked at the BHG guidelines and the threshold and where we should offer the surveillance for colorectal cancer, we sort of came up with a threshold of 1.5 adjusted risk ratio to be a threshold for when we would begin screening in these population groups. However, we know that post-colonoscopy colorectal cancer in IBD, we saw a lovely slide, admittedly from some old data. This is slightly newer data, but nevertheless, there's still significant misrate of colorectal cancer in IBD. Does colonoscopic surveillance in IBD actually prevent colorectal cancer? Well, I'm sure you've seen these. It's quite old data now, but there is some evidence that it does favor surveillance. So it does reduce the risk of cancer and colorectal cancer death. And how does it do that? Well, this is really what we would say, is that what we're trying to do is we're trying to detect more cancers at an earlier stage. So trying to detect less cancers that are GIEQs or Cs. So when do we start surveillance? Sorry, just a slide going. So we know the historical colorectal cancer risk